Welcome everyone to this week's episode of the Bariatric Nutrition Coach podcast. And I have a very, very, very special guest with me today. And it's Dr. Simon Monkhouse. And in a minute, I'm going to hand over to Dr. Monkhouse to share a bit more about what he does. You may know Dr. Simon Monkhouse from Instagram because he has a wonderful Instagram where he really shares wonderful information about bariatric surgery from a surgeon's point of view. And Dr. Monkhouse is a consultant weight loss surgeon. He's based in the UK, in the London area. And we're going to talk today about a very common topic and struggle, which is weight regain. So welcome, Dr. Monkhouse. Thank you so much for your time.
No, thank you for having me. It's a pleasure to be here.
So would you like to share a bit more about what you do in your practice and also the reason why you decided to go on Instagram? I'd love that. I'd love to hear.
Yeah, so I'm a consultant weight loss surgeon. I've been a consultant for 10 years now, and my primary focus is on helping patients living with obesity. It's a real problem, not only from a medical point of view, but a massive problem from a psychological point of view. And I think that is where I get my passion and my love for my specialty, because you not only can fix a problem by doing some surgery, but you can help change somebody's life from a psychological perspective. Because what I do is not a sole effort. What I do is a team effort. And we have a massive team around us of dietitians, psychologists, and the transformations we see are huge. It's wonderful to be able to put somebody's diabetes into remission, but it's more wonderful to see someone grow in confidence and achieve new career goals and relationship goals. And that's all down to just this battling this disease of obesity from all different angles. And that's where I get my passion from. And the reason I set up my Instagram was I just realized that people living with obesity, number one, didn't have a voice that was loud enough. There's so much stigma out there. And when patients go to seek help from medical professionals, they often get rebuffed and they get told, just eat less and move more. And they just shrink into the shadows and live their life sort of just with this horrible burden of stigma. And so what I wanted to do was to put a very educational, inspirational account out there that would allow patients to realize that they're not alone. And also, most importantly, that for most cases, the disease of obesity is not their fault. There is a significant physiological metabolic problem going on that is not under their total control. So releasing the stigma and inspiring and also giving them access to medical information that they wouldn't seek through their own
Yes.
means. And yeah, it's grown organically over the last 10 years. And I think there's 10,000 plus followers now.
Yeah, that's wonderful. Look, that's one of the reasons I set up my podcast is to extend my Instagram is about education, more voices talking about the disease of obesity. And what you touched on there, I think, is really relatable in Australia with respect to people are still going to their primary care provider and being told to eat less, move more. And while things are shifting, I think globally, and the research is showing that we're now being overweight, the obese is classed as a disease, there's still so much way to go. And so, yeah, the feeling of shame, I think, really is such a big weight on people's shoulders. So, no, it's wonderful. So, I think we're on the same path in a way. Obviously, you're doing the surgery, and we're all together going to help the whole area of bariatrics get much more coverage and visibility. So thank you. That's wonderful. So we're going to talk more about the topic. We're going to talk about say, weight regain. What are your thoughts when I say weight regain? What comes up for you as a surgeon from your perspective?
Yeah. So when we're talking about weight regain, we're talking about people who are post-operative. So they are people who have had primary or revisional weight loss surgery. And generally speaking, that surgery is either gastric banding, sleeve gastrectomy, or gastric bypass. Those are the sort of three main surgeries that are still out there. gastric banding is actually an obsolete operation now, and very, very few people put new bands in. That's been about since 2019. And that's fine that very few new bands are being put in, but there's a lot of patients with gastric bands out there because gastric bands have been going in since the early 2000s. And weight regain is basically where you reach your lowest steady state weight post operatively. And usually that happens around 12 to 18 months post op. And then in the years that follow, weight regain is something that can happen. And the first message to say that a degree of weight regain is normal and expected. So when you get to your lowest weight, particularly following a gastric bypass, because that seems to have the most significant hormonal and metabolic shifts associated with it, that is not the weight that your body will settle at. So you get to your lowest weight, and then over the next 6 months, you start putting weight on again. And then that is when the patient starts freaking out. That is when the patient goes, the surgery's not working. I'm a failure. What's happening? I must be doing something wrong. And getting the message across that that's absolutely not the case and it's expected, it is actually very helpful. And you will reach a new plateau, which is where your body is in its happy metabolic place. And we give it this sort of concept of the metabolic set point. It's where your body wants your metabolism to be at. And being or living with obesity in the first place, by definition, means that your metabolic set point has been artificially raised. And what surgery does is it brings it back down to somewhere near where it should be, but very rarely at a normal weight or normal BMI. So we don't expect surgery to get you to a normal BMI. We expect you to get into the overweight range rather than the normal, in inverted commas, or underweight. So you have to set your expectations. That's very important. And there are a huge number of reasons why weight regain beyond that normal expected may happen. And because patients have been through surgery to address their weight, often their first port of call is to contact their surgical team and say, what operation can I have now? Why this operation doesn't seem to be working so well for me now? What operation can I have? And it's absolutely the wrong way to go about things. And doing more surgery is often the wrong thing to do. The reasons for excessive weight regain tend not to be surgical failure reasons. They tend to be primarily psychological reasons. So we see patients who are slipping back into emotional eating patterns and losing that self-control potentially that was very strong in the early days of surgery and in the early days post-operatively. And it's getting on top of the emotional eating that isn't really key to trying to put this process in reverse or halt this process.
Totally agree. There's so many things there that I talk about all the time. And I think it's so important that people know whatever, when I say get to your lowest weight, you'll never stay there. You're going to come up a bit before you plateau off and you level off. And I also talk about going up and down a little bit and is really normal, whether it be a month or over a year, but really being clear about where's that point above which I need to go into action. And yes, first action is not always going for another surgery. It's actually someone to support you to change your behaviors, to uncover. I talk a lot, Dr. Monkhouse, with my clients about learning your patterns and your triggers for your overeating and setting yourself up with that. So that's really, really wonderful. So if a client or if a patient comes back to you with weight regain, I'd love you to share what you do, how you manage that with.
The first thing that we do is make them feel safe. They are coming back to us with a sense of shame and embarrassment because they feel like everyone else is doing well. And they are the one person that has, in inverted commas, failed this process. So number one thing is to make them feel safe and secure that actually it's very common. It's part of what we see day in and day out, and we can provide help. So again, trying to take away any stigma attached to it. and the shame, because they started this process pre-surgery in the first place with a sense of shame.
Mm.
And that sense of shame is so damaging. So it's very important in our support groups and in our online pages that we release them from that sense of shame. It's almost just part of the normal process. You've had some surgery in the first 5 years, you'll probably get some regain. It's normal. Come see us, we'll help you. So once we're over that barrier, it's the multidisciplinary approach again. We get the dietitian to do their thing, sit down, food diaries, look at what's going on, look at empty calories. Very often we see excess alcohol as part of the post-operative regime. And some of that is what we call addiction transference. So patients originally were often getting something from a dopamine hit from excessive sugar and excessive eating, and that gave them a temporary high. And you can't get that after surgery because you're restricted on volumes you can eat and types of food you can eat. And so often there is search for a dopamine hit somewhere else, and be that through excessive exercise or alcohol. And quite often, unfortunately, it's alcohol. So we have to be very careful to counsel patients around alcohol. And the calorie load of alcohol is not something that is registered by a patient because it's a liquid. They think that calories are only in your food. But actually, if you're drinking a couple of bottles of wine a week, that's a lot, and that's a lot of calories. So that's important to break down from the dietetic side of things. And then very clearly, the psychological assessment is important. And it's not a one-off psychology review that's going to change this. It's often therapy. It's a course of psychotherapy, mindfulness, resetting the way that you think about things, sort of having a shift in the mindset. And these things can really help. And then when those things are in place, then we can talk about, do you need medical or surgical intervention to help you? Is your weight gain so excessive that we need to intervene? And nowadays we've got medications that can help with this, which are really, really helpful in this setting because it saves the risk of having to go through further surgery, which by its nature is higher risk than the primary surgery. So going through further surgery is a riskier strategy than having your first surgery because of scar tissue and difficulty of the operation. So the new medications like the GLP-1 analogs, the Wegovy's, the Mounjaros, they can be very helpful in this setting.
Yes, and I have had many clients and have clients that are using, and call them like an extra tool in our toolbox to,
Exactly.
yeah, to help manage the appetite and really use it strategically. How do you feel? Well, there's quite a few people in the area of weight loss surgery I've talked to feel that people are relying on these medications, feeling that then they don't have to have surgery and that it's going to solve their issues, their challenges with obesity, and it's decreased surgery rates. And I've heard some interesting things, and I'd love to hear your view.
So the thing with these medications is I feel that they don't allow you to develop a healthy relationship with food. And that is key to long-term success with weight loss. So after surgery, you can eat normal food and get your proportions of protein, carbohydrates, and vegetables all in the right order, and you can develop a healthy eating pattern. With these medications, they tend to switch off your appetite and you just don't have the drive to eat. So quite often people don't eat or they forget to eat and they start losing weight through not eating enough or not eating the right things. And when those medications stop and the sort of inhibition of the hormones is lifted, you suddenly become hungry again. And then you sort of go back into to eating. So you haven't used that time necessarily that you're on the medication to develop healthy eating habits. You've just been reliant on a medication which is off your hunger essentially. And I think that's a problem because they are successful, but also the rebound is quite significant when you stop them. And that's why I think it's a useful adjunct to use alongside dietetic and psychology just to help lose a little bit of weight in the short term, to help your mobility, to help your energy levels, to help your psychological state, but not to be used as a long-term tool to keep the weight off, because it's not giving the right long-term vibes to me. It's a short-term fix. And the other thing is that medication is unlikely to replace surgery because of the extent of the weight loss that can be achieved. So I would say that medication weight loss is equivalent to gastric balloon weight loss. And there's no doubt that medication has almost eradicated the gastric balloon market, but I don't think it will replace surgery, because with surgery, people need to lose a significant amount of weight. And sometimes, not talking in stone, sometimes patients need to lose 12 stone in weight. And you're never going to achieve that with medication, but that is achievable with surgery. So surgery and medication are working well together and can be complementary. Medication and balloons are kind of polar opposites. And I think one of those will win the battle. I don't think there's going to be room for balloons and medication on the market.
My feeling is that they're getting so much publicity. This is Oprah, other people are talking about it. And it's a bit of a, not a fad, but a bit of a wave, and it will settle down in time and people see it for it's a short term and not that longer term intervention. But no, thank
Yeah,
you.
but then interestingly, the medication development over the last 5 years has been phenomenal. So we started with Saxenda, and then that being replaced with Ozempic, and now that's being replaced with Manjaro. And Manjaro targets two hormones in the metabolic weight space, whereas the other ones target just one hormone. And it's not going to be long before a medication targets 10 hormones.
Okay.
Um, and I think medications will become better. And I definitely think it's a future for helping metabolic disease like this. We're not there yet, and surgery still has its place, but I don't know if we'll be having this conversation in 10, 15 years' time.
Thank you for that. I'd love to go back to the topic of weight regain and where people reach their lowest weight and then they come up and they plateau. This is probably in the last 6 months, a lot more about set point, that it's easier to keep your weight at that point. Being really, you need to self monitor and you need to keep track of your weight and what you're doing. And if it starts creeping up, being really proactive earlier. And I talk a little bit about you going down the road and we've got I don't know if you call them cat's eyes in the UK, but you got the little bumps
Yes.
on the side and you kind of wake up. And I say to people, and my clients. So it's about we're here now, and it's very normal to bob around. But what's that weight that makes you, dun, 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 I need to go back and do this and check. I need to really be proactive and having maybe a lower threshold than they possibly think, because people say, oh, I gained 5 kilos, or I gained 15 pounds, or I gained 20 pounds, and then I thought I'm going to do something. Do you ever give guidelines with your patients in your surgery center around that, or what are your thoughts?
We don't have a specific number in mind, but I think as you allude to there, it's when your weight starts to affect you and affect your confidence, affect your work life, your home life. That's the point that intervention is needed. You just reminded me there. Only yesterday on our patient support group, a patient was putting a post up there about she's 2 years post-op and she's gained quite a lot of weight back, and she just can't understand it because everything is in check. Her relationship with food is good. Her psychological state around food and health is good. She's exercising, but yet she's still putting weight on. And she was just sort of putting a post out there to warn patients that it is not always about what you're eating and you're doing. And her weight regain was down to an endocrine problem. So she developed some thyroid issue as a consequence. Well, I don't know if it was a consequence of what she'd been through or not, or whether it was random. And when that was addressed, she started to get back on track. So not all weight regain is down to the failure in inverted commas. It can be down to other things. So it's really important that part of our assessment is to think about other causes that could be responsible for weight regain.
Oh, definitely. And I suppose I had that as a thought, and the way I would approach it is check out what's happening, get support. Don't think, oh, I just need to look after this by myself and I don't want to talk to anyone. So lean forward, reach out for support, understand about more what's going on. So that's definitely agree. I want to come back and I wrote it down as a note when you were talking about alcohol, because that's what I see that a lot. And also I would put even it's the slider foods in that same bucket of where people go. I remember reading I can't remember the name of the study, a really wonderful study that they did over, a group of people that had a sleeve gastrectomy, and they gave them a certain amount of alcohol before their surgery. And 5 years later, they gave them the same amount of alcohol and their alcohol went higher. The blood alcohol went higher with that same amount of alcohol and it stayed in their blood locker. So I think that's not known a lot, that how you metabolize alcohol changes and it's compounded. It's more than just because they might think I'm drinking less than before.
Yeah.
So yeah, I don't know if you've read any similar studies.
Yeah, I think our understanding of how the surgery affects your metabolism and your physiology is still developing. I mean, people think of a sleeve gastrectomy as you chop out 80% of your stomach and that's how it works. And actually, it doesn't work through that. It works through significant changes to the hormonal profile, and that's going to affect absorption of various things. So, our simple concept of what we do is probably not quite right. And I always think it's interesting that we've been doing this surgery for decades now, only just understanding how it works.
Mm.
So we started doing the surgery because it worked on a few people, but we didn't really understand how it worked. So we just did it. And now we're beginning to understand how it works. So it's sort of slightly the wrong way around. What I wanted to say on the topic of weight regain, which is particularly relevant to your Australian patients, is post-gastric band weight regain, because gastric banding was very, very predominant in Australia. And I think you guys were the world's most prolific gastric banders for a long time. And it's the reason it's become an obsolete operation is that it's very, very common to have significant weight regain after a gastric band. And the reason for this is the gastric band forces you into a bad eating habit. So the concept originally was to limit the amount of food you could eat, a belt around the stomach to limit the capacity of the stomach. But actually what it did is it made it uncomfortable to eat. And so people then go into the slider food territory because it's easier to get down, and the alcohol and the pain on eating forces you to become a disordered eater. And so often removing the gastric band as a surgical intervention early, rather than spend the time that you would take to avoid revisional surgery with a gastric bypass and a sleeve is quite long. Revisional surgery has to be the last resort. With a gastric band, getting the band out early is actually one of the best interventions, because you can then start to rework on healthy eating relationships because you don't have that pain on eating. So gastric banding is a little bit different in terms of when would we think about surgery.
And totally agreeing with the eating behaviors, really disordered eating that people develop with a band. So seeing that often in Australia, from my experience, surgeons will remove a band and then allow a good 3 to 4 months of healing before they then move, say, to a sleeve gastrectomy. And yes, the
Yeah.
challenge or the goal in that period is to really maintain weight, but not all surgeons are encouraging or really tackle it in that way. And just kind of the education starts when they come in for, say, a sleeve gastrectomy but no, yeah, totally. I haven't heard of anyone having a band in. I'm sure there are some people doing bands, but yeah, we thought it was the answer, the less invasive answer to all the problems of the world, so to speak, and it didn't end up being that. So,
Yeah. Well, it didn't address the disease
mm,
of obesity at a hormonal metabolic level. It
yep,
was a physical barrier to eating. And we know now that actually eating is the symptom of obesity rather than the cause of obesity. So it was tackling the wrong end of the problem. And that is why the bypass is still considered to be the gold standard operation, because the metabolic shifts are so profound following that you have to treat the disease of obesity at its root, and its root is not eating. Eating is often driven by the metabolic disorder.
The bypassers such as Sardius SIPs are becoming much more common in Australia. So is that something that is happening more in the UK as well?
Yes, I mean, I think all of these operations are evolving, and we see the so-called mini gastric bypass, which is actually not mini at all. It's as invasive as the original bypass, but it's just one joint rather than two joints. So in our world, we call it the one anastomosis gastric bypass rather than mini.
Yes.
But anyway, they're evolving. But my concern is with the operations that are coming out and the sort of newer operations is quite significant amounts of bowel are taken out of circulation. And
Mhm.
the more bowel that is taken out of its usual functional process, the more likely you are to develop malnutrition if you don't keep up with your vitamin intake and your calorie intake. And you're pretty safe with a sleeve gastrectomy and a routine standard bypass if you do all the right things with it and technically you've done it correctly. But some of these newer operations, and even the one anastomosis gastric bypass, huge volumes of bowel are taken out of circulation, and people are getting long-term deficiencies which we didn't appreciate at the start. And these deficiencies are only becoming evident 3-4 years down the line. So
Mhm.
although it's technically possible and there's an accolade of being the person who's doing the newest operation, you got to be slightly cautious because our digestive systems are great when they work well, but when they are altered or not working like they should, they can be very damaging to our health.
Look, agree. And the follow up and I suppose vigilance around vitamins is definitely, yes, from a nutritional perspective, yes, something that's really important, especially with the more significant bypasses. So that's wonderful. Before we wrap up, anything you'd like to share? Because we've covered a lot of great information today. And I so appreciate you sharing your expertise. But yeah, any final thoughts, Dr. Monkhouse?
Well, I think it's not necessarily a final thought. I think it's like an initial thought that we started off is the shame and the stigma that people experience driven from within themselves and other people is down to a condition that is almost certainly out of their control. And there's no other disease that we would stigmatize quite like we stigmatize obesity. And it's really important that your listeners and the general public get the message that this is a disease, this is not your fault, and there are interventions and help to get things back in check, and you don't need to suffer.
Exactly. Totally agree. And I use the analogy of people having diabetes. Do you self monitor? Do you think you need to manage it on your own? Do you feel embarrassed? And it needs to be a lifelong journey. And there's so many kind of corresponding aspects with respect to the disease. So I think it's great we talk about it, more people talk about it, and it gets out there. So people don't feel that shame when they do regain some weight and they reach out for support and also don't expect themselves to be able to manage it by themselves. So thank you so much for your time and for jumping on so early. And I really appreciate it. And everyone listening, thank you so much for getting to this point in the podcast and listening. And if you would like to listen to Dr. Monkhouse more and check out his reels and his Instagram, Dr. Monkhouse, where can they find you?
So I'm on Instagram, and the handle for Instagram is at weight loss surgeon.
Beautiful, beautiful. And then you've got a great website. I was looking at that. And I know you've been on other podcasts. It's wonderful to be able to, yeah, find you in different places and listen to you sharing your experience more. So thank you so much, everyone, for listening. And I really look forward to being back in your ears next week. Bye for now.